Hello, everyone, and welcome to another episode of the podcast. Bo and Ledden, joined by Shaun Brewster. And Shaun, today we are talking about the why over the what. So, we're going to talk all about understanding why different techniques or modalities have the effect that they do, as opposed to just doing the specific modality or intervention.
It's the difference between a technician and what some would call a magician. You know, you can just do the techniques, you can just do the thing and use the tools versus someone who actually makes the magic happen and gets the outcome, the desired outcome to reach fruition. So using the tool, I think, as the example of the what, it's very easy to collect tools as a health practitioner, as a manual therapist. We're talking to manual therapists here. Um, you can go and do a lot of courses. You learn online. You can go to face-to-face courses. You can do all sorts of things and collect lots of tools, lots of skills and abilities, the cupping and the needling and the joint mobilization, the taping and the scraping and all these other different things you can learn. And you think, well, great, I've got all the tools now. I'm a complete technician. I'm a complete practitioner. But essentially, once you've got all the tools, all you are is a technician. To be able to use them really in a very skilled and exact way, that requires an understanding. To be able to clinically reason, you have to understand the reason things work, not just how to use them. And I think that's what we're talking about here is the why over the what, is understanding the reasoning behind it.
Yeah, and that's so important. Once you know that, you can apply anything. All right. But if we've got all of these skills and you look at them and go, how different are they really? Well, probably not a whole lot different as far as mechanisms go, but we've got to understand the principles of action or proposed mechanisms of action. But going back to understanding the pathoetiology and understanding the signs and symptoms and the history that typically relates to these presentations, that's not as sexy as providing techniques. A lot of people just want to provide the techniques, but I say this to other clinicians and students that if you're just providing techniques, it's like prescribing a medicine without knowing the cause or without knowing actually what it is. You can provide an antibiotic or Panadol or some form of analgesic medication to decrease the pain, but without knowing what's causing it or what's driving these symptoms and the underpinning pathoetiology of this presentation, well, it's probably less likely that you're going to get the most favorable long-term outcomes. And to be able to educate a patient is probably, in my opinion, the number one treatment technique that you can do. And so you've got to understand what it is to be able to educate the patient about it before you then provide any sort of hands-on application of a technique.
I think you touched on it before when you said, you could do all the sexy techniques, you could do all the skills, and it looks good. And for the patient, it probably feels special because you're doing lots of things to them. But when we drill down to those proposed mechanisms of effect, how does this particular massage technique reduce pain versus this particular cupping technique versus this particular dry needling, or whatever it might be, exercise? Um, Often the mechanism that is employed to reduce the person's, say, pain experience is the same. It might be the same neurological reflex or chemical exchange that takes place to reduce the person's pain experience. It's just achieved in different ways. And you think, well, okay, well, why do we have all these skills and tool sets? Well, maybe because sometimes it comes down to that very human element of the patient perceives a different modality or technique to be a better experience for them. They have a more positive experience around massage, for example, than they might around needling, and vice versa. It could go the other way if we're using two examples. And so for that particular patient, it makes sense to have a different set of tools to be able to employ that tool. But it's not just about what the patient likes when we're trying to achieve a specific outcome. Is what do they like? What physiological mechanism is at play that we can potentially influence with our modalities? And then what's the desired outcome? Because sometimes you could use the thing they like for the thing that they need and get the wrong effect because the dosage is wrong. Or maybe you're treating an inflammatory condition versus a degenerative condition. Or maybe it's a chronic presentation versus an acute presentation. And we might be doing the same thing on that same patient at another time, and it produces a negative outcome versus a positive one. And so, like you said, it comes down to this pathoetiology, understanding physiology, pathophysiology. How's the body behaving now? What's the desired outcome? What are my tools, my weapons to select from that will get me going in that direction? Does that fit with patient preferences? And does the patient situation today, in this moment, match all of that to be able to choose that one thing? There's a lot of things to weigh up there. And you think, if you're a new practitioner, you go, well, that sounds way too complicated. I think I'll just go back to doing all the modalities I know on every patient because it blows them away, from an experiential point of view. But if we're trying to achieve results, we have to consider these desired outcomes and the things that get us there along the way.
Yeah, we talk about this a lot to say, someone might ask, what's the best treatment for back pain? Well, it depends. It depends on their history, their signs and symptoms, the longevity of the symptoms, the irritability, their behavior, their thoughts, their beliefs, a number of different factors. Because you said it before that pain, it's a perception and it's based on a number of different factors, and how we influence those different factors can influence the outcome. And this is a great quote from Butler and Mosley, is that the back doesn't have pain, the person has back pain. And so shifting away from looking specifically at the structure to the person and how they perceive their pain experience, and the number of different factors that can be contributing to that. So it probably is less about this specific technique that you apply. There's no one best technique for anything, just the same as there's no one best exercise for anything. It really comes back to the patient's preferences of what they enjoy and their expectations. So all of those factors are really important when we're looking to manage pain. But if you can start from the top with a really thorough assessment, because if you can go through a really thorough assessment, that demonstrates to the patient that I'm being taken really seriously here. They're being really thorough with their examination. Okay, you're explaining to them throughout that entire examination process of what you're doing, why you're doing it, and what it means. All of this can influence the multi-dimensional nature of pain, but it can help to decrease their level of threat. They might have previous beliefs that something is damaged or structurally unstable or whatever that may be. And going through that thorough assessment to start to, I guess, decrease some of their stress and their worry about their perceived pain or their beliefs about what's going on. So using that as a really thorough process, and then say, hey, this is what I think is going on here. This is why, there's not so much to be worried about. We've ruled out any serious red flags and this and that. This is what I would propose as an effective, as a treatment intervention. Is this something that sounds like it would be beneficial to you? All right. And so this is where we start to combine all of these things together. And, someone might perceive exercise to be damaging. And so if we go back to understanding what it is and why they may have pain, and talk to them that a tear may not necessarily mean that it's more weakened, or that it's more likely to tear even further with exercise. Actually, tears respond really well to movement and exercise. And so it's the same sort of thing with providing a manual therapy technique, using that to modulate their pain. It's not that you're putting something back into place because it's out of place, or lengthening something because it's tight. It's modulating their experience, and perhaps providing them with a little bit more comfort and reassurance about their body, which allows them to move with more ease and less pain.
Well, that's really good. I like the idea of, and also explaining why you're going to do what you do. I something I've used a bit myself and I think is really effective is also explaining what you're not going to do. Like, here's what I'd like to do today, what we're not going to do. And then you might be listing the things that maybe the patient's expecting. So maybe they've been to see a bunch of massage therapists before and they've had some good experience because they get some pain modulation. You go, today, I'm not going to do a lot of massage because, and then you explain the pathophysiological reasons why you think massage might not be the best choice today. And then you can helps them kind of go, right, let's narrow my focus now to what we need to do, rather than getting stuck in past experiences of what I've used before, but maybe haven't given me long-term results. And so tell them what you're going to do and why. Tell them, I think it can be useful to tell them what you're not going to do and why, and to clarify that so it doesn't leave any doubt about why you might be leave something out of the consultation. And then you very specifically, like you said, check in with them. How does that sound to you? Not to be misled, not to be led in a different direction by the patient. That's not why we ask them, does that sound okay to you? And they go, well, actually, no, I'd just like to have a lot of dry needling in my neck if you could. And you go, oh, okay, fine. Let's just do that. That's not what we ask them. We want to make sure that they have some buy-in, that they have some belief in your explanation. And if they go, oh, yeah, but I thought we could maybe do this other thing. Okay, I obviously haven't explained the situation well enough. Let's go into this in a bit more detail. And then if they're still stuck in the idea of wanting something else, then maybe you're not the practitioner for them. And that's entirely okay as well. And so sticking to your philosophical approach to treatment and sort of saying, here's what we're going to do, here's what we're not going to do. How does that feel? How does that sound to you? Great, let's go ahead. If not, discuss it further, maybe referral if required. But what we don't want to do, Bo, is what I saw the other day, scrolling through one of the social media platforms. I saw a very well skilled and highly qualified health practitioner. I won't name them or to say what modality they were doing, but they were conducting a strength assessment on a patient, both sides through shoulders and neck, some very specific orthopedic and special tests. And then they identified, it was all sped up on the video, so you could see the whole thing playing out in real time, but it's sped up. And they identified a weakness and an obvious problem on one shoulder. And they then laid the patient down, treated the opposite side, went back to the injured side and did exactly the same thing. So it was a specific recipe of 2 or 3 different modalities, cups and needles and other things placed in exactly the same place on both sides of the body after doing a very thorough physiological assessment on somebody and identifying some real differences from one side to another in strength and function, and then did a symmetrical treatment on both sides of the body. And so this is a danger too, like the why over the what. If you're going to go to the trouble of doing a good, thorough physical examination on somebody, take the data and do something with it. Don't do it to show off. Don't do it to say, look at all the tests and things that I know, to demonstrate to the patient that they're uneven or unbalanced, or, that there's something wrong on one side, and then just do whatever you want at the end of that treatment, because that does not demonstrate the why. All it demonstrates is that you know some things, how to do them, but you probably don't know why you're doing them.
Yeah, great example, like there's all sorts of different manual techniques out there that you could do, but you don't need to throw everything at one person. And so an example, if someone has a movement related pain, so they've got low back pain that hurts when they bend forward. All right. What you probably wouldn't want to do is just say, right, lay on the table, let's treat you for an hour, get back up, let's see how you're feeling. What you probably would want to do is select a technique that incorporates movement into that treatment. All right. So if you can provide a manual technique, such as an active mobilization or mobilization with movement, that you provide a mobilization, see if that decreases their pain immediately. And then as they bend into that movement, does that change your pain? Great. Now we're getting you more comfortable with that movement. We're changing your experience of bending forward and that the association of movement with pain. Let's get you a bit more comfortable with that. Do that a few more times. Take your hands away. Now, can you do that on your own? All right. That this whole self-efficacy coming into it, that they're in charge, they're in control, not the practitioner. Getting them to repeat that, getting them more comfortable with it. So then it starts to become more of a learned behavior. That's what's really important, because you've selected the right technique based on a physical assessment, based on their pain presentation, and hopefully their goals and their outcomes, what they actually want to get out of the session. They want to be able to bend forward without less pain, or sorry, with less pain, or they want to get back to something that they enjoy doing. So we need to take that and incorporate that into the session, because that's using the why with the what, as opposed to I'll just do what I normally do and hope for the best. Because in that instance, where you're just going and providing any technique, you will probably have a short-term pain modulation effect, but less likely to have a long-term outcome-based effect. And so that's what's important, is as to understanding what you're doing and really why you're doing that. And that can help you to select the right technique as opposed to just throwing everything at it.
Yeah, you nailed it on the head. Like, clinical reasoning comes down to understanding the reason. Like, you can clinically reason the use of just about any modality if you want to. We've all got biases in the way that we view things, of course, but understanding the why comes down to understanding the reasons for that thing. And the reason for that thing has to come from the patient's physiological state. What's going on for them? What are we trying to influence? How can we influence that? Why would we choose this technique over another one? And you talked before about, and this is something I know, Bo, you and I both harp on about in all the courses we teach. It's like you can't just throw everything you've got, like you said, a handful of darts, throw them at the dartboard and think, well, one or two of those darts were a good shot and the rest were a bad shot. You just threw them all together. You don't know what was what. And so if you do 5 or 6 things in a treatment and only reassess at the end, you don't know which one of those 5 or 6 things made the biggest difference. And I always come back to this example of something stupid I did years ago, which was I used to, when I was younger, I used to love cornflakes for breakfast, right? And I used to love having a glass of orange juice with cornflakes. And I thought, I wonder if I just use cornflakes, but put orange juice in the cornflakes rather than milk. They're like two of my favorite things. I'm like 16. I thought two of my favorite things together. It must make that thing better. More of something doesn't make it better. The right amount of something makes it better. I was put off cornflakes and orange juice for a really long time because the combination of them was bad. Like, you could do all the right things in a treatment, but put them together at the right time, and then the dosage is out. Maybe you've done too much for the patient. Now you've got a bowl full of orange juice and cornflakes. It's disgusting. Nobody wants that, right? It's like, it's a silly example, but I hope you get the point. If you could have massage, joint mobilization, and I don't know, corrective exercise prescription could be the thing that makes the difference for the patient. But if you just do them all together, patient walks out confused, don't know what they felt, don't know what they heard, didn't understand anything, and they walk away with cornflakes and orange juice. So you want them to have a good experience. Do one thing, get feedback on that. How did that respond? Do you understand? Yes, let's build on that. The next thing. Or maybe it's more of the same thing. Maybe you just need the one. And you'll never know that unless you, the only way you'll know why that's the one thing is because if you do it, test it, retest, do it again, retest it, do it again, retest. It's plateauing. That one's done. Maybe we're going to move on to something else, or maybe we're finished.
Yeah, and that's just engaging the patient in the consult as
Yeah.
opposed to purely passive, sit back and relax, I'll do the work. No, well, we've got to work together and you've got to be actively involved to get the right outcome. I can't actually do this for you. I am not a magician, but I can help to coach you along the way. And, so much of even what I do is just starting to incorporate mindfulness into what we're doing. What are you noticing when you go into that movement? What happens if we explore that a little bit more? So showing the person that they can do this, it's okay to experience some discomfort. Let's get a little bit more comfortable with that, or let's recognize what it is, recognize it, label it, but don't be scared of it. Okay, so understand what it is, and this all comes back to our perception of movement and sort of changing our perception of something that could be perceived to be harmful or dangerous to making it less threatening or less dangerous. And this is all these behavioral change strategies that come into it. If someone's had chronic low back pain for years and years, they've had maladaptive movements that will go with that, maladaptive behaviors. So changes in the way that they think in their perceived level of danger. And so we need to try to influence that. And this is how we can incorporate pain neuroscience principles into manual therapy approaches. And sometimes it's not as sexy as providing, you can't film a lot of this and put it on Instagram and get hundreds of thousands of likes, because it's basic nuts and bolts about understanding what pain is and how we could influence their perception of pain and get the patient more comfortable with it, as opposed to just doing everything that you can manually. So I think that sort of speaks a lot to it, is really engaging the patient in what you're doing, educating them about pain, educating them about what you're doing, educating them about the assessment, what it is, what it isn't, educating them about your proposed treatment intervention, getting their expectations, getting them to explore their pain and really ask those open-ended questions so they are an active participant as opposed to just telling them what you're going to do and what you think it is and what you think the cure will be. Cure. Um, but having that real shared decision making throughout the consultation is really where you're going to get the best results. And so um, I think that's really important, but it sort of comes back to knowing why you're doing it and not just providing a treatment and hoping for the best.
Exactly. And the why is the key thing here, isn't it? The why over the what. We've been talking about why you might choose a particular modality over a particular modality, or why you might design a treatment a certain way. But taking the patient on that journey is important, isn't it? And sitting down with them, and you're right. If you or I or someone else who maybe knows their stuff really well was to film that consultation, that would be the least useful thing for them to put in their social media, because it's just two people sitting there nodding at each other, answering questions and having a discussion. And then one person over the course of that consultation developing more confidence and understanding in their own body and their understanding of why they're feeling what they're feeling, and walking out feeling empowered. You can't film that. Like, it's a difficult thing to make look sexy. And so the why over the what in the consultation, in the history taking process and talking to the patient, is helping them understand, maybe ask the question, why do you think your knee hurts the way that it does? And then they explain to you their perception, their beliefs around that. And then you can explain to them, maybe you can adjust that reality for them by providing more information. So why do you think it's been hurting you for this many years? I think it's bone on bone. Okay, well, and again, we can adjust their understanding through that. So asking the why, flipping this around a little bit and say, asking them why helps us get a better understanding of where they are, and then we can meet them there and then lead them in a slightly more optimistic and beneficial direction based on that understanding of their why.
Yeah, definitely. And we all have our own biases, whether we like it or not. But something that I just sort of to reflect on is, every patient, every patient's pain experience is individual. Is everyone's experience is different. So if everyone's experience is different, then why do so many treatment consultations look the same? And so if you think about if you had a fly on the wall watching all of your consultations, would they all look pretty much the same? And if they do, then we've got to question that. Are we really understanding the why here before the what? Are we really understanding why we are performing that treatment for this particular person? Okay, and I think that's something that could be quite important to reflect on. It would be like any person that walks in to a doctor's surgery with an illness, they get prescribed the same medication.
Yeah, yeah, great example. That's a really good reflective exercise, and it sort of screams or calls out the idea of recipes for different presentations, doesn't it? Like, okay, here's the treatment protocol for shoulder pain, or here's the treatment protocol for frozen shoulder. It's a classic one. Like, here's what you do for frozen shoulders. Well, there's a lot of things that go into an adhesive capsulitis, and there's a lot of different experiences the patient might have, and where they are in that journey will influence what you might do, and how sensitive are they on that day. Like, using it as a realistic example, a real example. Like, all of these things should influence the way we do what we do and why we do what we do. So let's all put that fly on the wall, Bo. I reckon let's reflect on our last set of patients and go, well, what were the things that I did the same? Was there a clinically justified reasoning behind that selection of techniques or things that I did that were the same? Should I have changed any of those things? Could I have changed any of those things, or what would have been the different outcome? What other factors could I have considered about that patient that would have influenced a change? And these are, reflections, a powerful thing to be able to do. It's the thing, it's way more, I think, more powerful than getting feedback from people who might be observing or even participating, is reflecting yourself. It's like, what could I have done better? Why did I make those decisions? And then going back afterwards and saying, okay, well, if I was to do it again, here's what I might change. And then you get an opportunity to do that with each person, which is pretty powerful.
Yeah, and someone asked me not too long ago, what course should I do next? I've done nearly all of them. And I was just thinking, well, what you really should do is to be honest, go and learn about pathophysiology, read research articles. It's not the most exciting thing to do, but that will give you a really robust understanding about the why you're doing these different treatment interventions. Because once you've got that, then uh, it'll everything will be a lot easier. But it opens up the doors to other things. What else could it be? What am I missing? What do I need to look at a little bit more? The list of differential diagnoses increases, but it increases your understanding of being able to educate our patients about what it is, what it isn't, and your proposed treatment direction.
Great advice. I tell the same thing to people all the time. Like, what's the thing? The one thing, if I could go and study more of what would make you better, pathophysiology. The step before that, of course, is anatomy. You have to understand the parts before you can understand how the parts don't work when there's something wrong. And then the step beyond that would probably be psychology or pain science. How the mind and the brain and the nervous system work together to influence your experience within the pathophysiology, and the pathophysiology sits within the anatomy. So those things are so important. And you're right, it's the least sexy thing that you could give advice around. It's like pick up your old textbooks and understand what happens when someone gets an inflamed structure in their body. How does the body respond? What happens when there's a tear in a muscle? What are the things that happen within the tissue that happens within that tissue as it goes through the healing stages? Like, how does that respond? And then understand the psychology and the neurological processes that take place and the pain science around that that's the gold. And it takes a long time to learn. That's the downside.
Yeah, but it allows you to provide really good education. It allows you to provide realistic timeframes about what the person should expect. Someone walks in with acute back pain. You say, okay, look, unfortunately, this happened yesterday. You will have some high level of pain and sensitivity, probably for at least the next week or so. We do have these normal inflammatory processes that occur, and this is actually quite a helpful thing. In the meantime, here's some things that you can do to help to modulate some of the pain and the symptoms that are associated with this. But the good news is, based on what the research says and my clinical experience, that most back pain will get better within about 3 months. In that time frame, you may have some good days, you may have some bad days, but progressively we'll see a good progression of symptoms over time. And we want to start to integrate movement and exercise just based on that. Obviously, a bit more of an expanded summary, but the patient will go, "Oh, wow, it's not that serious." And then we might say these are some things that we want to look out for in the meantime. But at the moment, we're gonna apply a watch and see, wait and see, with some coaching along the way. And so that's pretty important because then they understand what to expect. They know that it will be uncomfortable. They know that they're going to have to wait a little bit of time before they get back to doing things that they really enjoy doing. But they also know that it's not going to affect them for forever. They're not going to be in disabling pain forever. All right. So I guess understanding how these presentations typically behave allows us to educate our patients with confidence. It provides them with more confidence, and it provides them with a lot less fear, anxiety, and worry about what's going to happen next.
Yeah, that's right. They're coming in with a story that they've told themselves about their presentation, which is the what. I hurt my back. The thing happened. And then the why is either a story they'll create for themselves or a story that's created for them. And so our job is to intervene with that story and give them the facts. So you talked about giving them the realistic situation, then you give them some optimistic outcomes, and then you give them a strategic plan. Realism, optimism, strategic. And you go those three things. Now I think that's what we're trying to do. Here's the reality based on the pathophysiology. Now, because of that, here's some opportunity. There's the optimism. How do we get towards that? Here's the strategy. You lay it all out for them. How does that sound? Good. Got any questions? No. Are you worried about anything? Are you concerned about anything? Is anything confusing? There's these things. Great. Let's adjust those and address those, and then off we go. Versus, oh, I've hurt my back. My dad hurt his back years ago, and he never played cricket again. So my cricket career is probably over. Like that's a story you'll tell yourself. The why becomes imagined as opposed to based on reality. And I think you make a good point there. It's like just lay out the facts for them, and give them something to aim for.
Yeah, and you could liken most musculoskeletal conditions back to, say, like a muscle tear, for instance. You know, a person injures their hamstring. They say, "Oh, I felt this bit of a pull at the back of my leg, back of my thigh, and uh, it feels a bit tight. I need you to rub it out." And so you would need to go back to your assessment. You would need to educate them about what that assessment shows and that the time frame that this would likely take based on what you found in your assessment. So you might say, look, based on my assessment, it's presenting like a grade 1 or grade 2 hamstring strain. Massage manual therapy to that area at the moment is likely to be unhelpful. What will be most helpful is to create a bit of a plan, some exercise, some loading to get you progressing back towards movement, so we can start this healing process. There will be an inflammatory component at this time. All right. And so you might have all of these techniques, but throwing them at that hamstring at that time will probably be unhelpful, maybe later on. But it's really important to know what it is first, so then you can actually provide the right treatment techniques or treatment intervention to get the best outcomes.
Mm. But I'm going to play devil's advocate for a second because I know there'll be people listening to that statement, which I completely agree with, by the way. They'll be going, hang on a second. I see athletes all the time the day after they injure themselves, sometimes the day of, and I have rubbed out a strained hamstring. I've massaged that calf that went ping, or the quad that cramped up or whatever. And it turns out that there was a little tear, and I did some really strong massage on that, and it rubbed it out for them. They were sorted afterwards. And so for every patient that's ever said, but I got it rubbed out and it was better directly after an injury, please explain.
Well, it may not have been a tear. It could have been a local contracture, a cramp. It could have just been a sensitive area. But at the same time, you could have a grade 1 tear that's not presenting with significant deficits in strength, but it could be really painful, really sensitive. There could be associated muscle contracture and sensitivity around that area. Um, but rubbing through that area, yeah, it might provide temporary relief, but it may not be helpful in the long term. And so we've always got to weigh that up and think about, well, what if there was an underlying injury, would I actually cause more harm than good? Um, and so, yeah, I mean, you could do treatment around it, treatment to antagonists, but at the end of the day, it comes back to understanding the mechanism of injury. If they've come in saying, yeah, I sort of felt, I can put it back to this point in time where I actually felt it, I felt that sort of sharp pain and I can point to it pretty locally, you're more likely thinking that there's potentially a bit of a muscle strain or a tear going on, as opposed to, oh, it was about 24 to 48 hours later and it's just pulled up pretty sore generally through that area. Less likely to be a muscle strain or a tear. So understanding the mechanism of injury is super important. But yeah, I mean, it would be like if you've got a sore spot on your body, you would often go and press and rub on that area because it might provide temporary relief, or it feels like that's what we need. But the body will have to go through its normal inflammatory process, and in that time frame, usually loading is going to be the best thing for it, as opposed to disrupting that area and potentially disrupting that inflammatory process.
Mm. Yeah,
It's
good
sorry, I'll
advice.
just add one more thing. It's
Mm.
sort of like the old mentality of rub out a cork. I used to work in sports years ago, and people would come off the field with a cork or present to see you during the week and say, "I just rub this cork out," and it's actually one of the worst things that you can do. So look at a cork at the same way that you would look at a muscle tear. Maybe less visible, depending on the grading, or might be more localized at a tear as opposed to a larger cork or contusion. But similar sort of mechanisms, damage to the muscle fibers. It needs to go through its inflammatory process, and then loading is often the best way early on. Manual therapy can certainly come into it in the later stages.
We're back to pathophysiology, aren't we? Understanding how the body responds to injury, trauma, insult. Um, you know, for anyone that sort of said, yeah, I've had my corked thigh got rubbed out or my hamstring rubbed out or whatever, I stretched out, some deep massage foam rolling that all kind of sorted it out. It took the pain away. Well, you're just modulating the pain sensation temporarily. And in the process of reducing the experience of pain, are you increasing the inflammatory response to a point where it's beyond its optimal levels? Or are you maybe even creating some more separation of fibers in the process? And so the patient's getting this band-aided reduction in pain, making them feel like, yeah, it's really good. It actually gave me a couple of days relief, but it actually prolonged then the healing process for them well beyond what it would have otherwise. It's like a mosquito bite. It's itchy. You want to scratch it. Should you though? Should you scratch that mosquito bite? It's not the thing that will help it heal faster. If you want it to get better, don't touch it. Let it take its natural course of history. There's other things that you can do to reduce that sensitivity. And like a muscle strain, should you just get in and rub it because it's sore? Well, scratching a mosquito bite takes away the sting for a minute, but it comes back worse because you've just created more of an inflammatory response. It's the same thing.
Yeah, that's a good example.
So this idea, Bo, of why over the what, we've probably come at it from every possible angle now. Like we've talked about explaining the why, about using the why in our selection of treatments, and the way that we design our treatment plan. Are there any other parts to this that you think people need to consider around not just recognizing the importance of the why and then making good decisions, but thinking about it more holistically?
Yeah, do you know what? That's the thing. Like we said before, that it's not as sexy to learn the why.
Mm.
I mean, I'm a bit of a nerd like that. I get really passionate about going into the research and the mechanisms in courses. And sometimes you just see people's eyes glaze over and go, "Oh, can we just get to the thing? I want to do the technique." And we even see that in like assessment-based courses where there's less people that tend to go for an assessment-based course than people that would go for a treatment-based course. Assessment is a lot harder. It's actually, it's not just A equals B. Sometimes it could equal that. It could equal this other one. It could be another direction. Maybe this, maybe that. It's a lot less specific, but understanding how to go through a bit of a process gives you a bit better idea of what you think is going on, and why you might propose a certain intervention. But yeah, these things they do take a bit more time, effort, and experience, I guess. All of that together will help to provide a bit more robust understanding of the why.
Yeah, good advice. Um, you're right. It's the least sexy part is understanding the why, but it's where the gold is. It's where, as a clinician, if you can understand the why, you can make better decisions. You can get to outcomes faster as well. You become more efficient, because just doing the what just gives you a whole heap of things to do, not necessarily a whole heap of information to sort through. So yeah, why over the what's an important one.
Yeah, couldn't agree more.
Good. Well, let's wrap it up there. Thank you everyone for tuning in once again. We'll see you on the next one.